Please join me in welcoming Professor Ingrid Scheffer.
Thanks, Jordana, for that lovely introduction. I have a confession. It is today that I was announced, and I had a working day with my colleagues for our next program grant, so I have had half a glass of champagne. It's the first lecture I've ever given with alcohol. So this was the title that Jordana and the team gave me, Women in Science on the Cutting Edge of Epilepsy Research, and I thought I'd share with you that lovely Loreal UNESCO, very French moment there. I renamed it, A Woman's Work Is Never Done, balancing science and medicine with life's challenges. So I hope I'm not going to be depressing, I hope I'm going to be inspiring here, but I thought I'd spend the first sort of third of the talk really about some of our research, and I could go on for days about our research because it's so exciting. But I'm really going to devote a fair bit of the time to points 5 and 6 because I want to inspire you about doing some science, and I want to inspire the young women. I'm not trying to be sexist here, chaps, but about why they should do it and the juggling acts that they have to think about performing. So let's start with the science. Epilepsy is common. It affects 2% of the population, and a further 3% of children have febrile convulsions or febrile seizures. They occur due to abnormal electrical activity in the brain, and we capture that on an EEG, which is an electroencephalogram. There are many types of seizures, and I'm a child neurologist, and so epilepsy is very pertinent because you can see 80% begins in childhood or adolescence. And we talk about epilepsies in terms of epilepsy syndromes. There are many different types of epilepsies. So why is epilepsy such a tough disorder to live with? Well, firstly, think about it. It's incredibly unpredictable. You'd be sitting here in this lecture and have epilepsy and suddenly you have a convulsion in front of everyone. This affects your self-esteem. It affects your daily functioning. You just missed a bit of a conversation because you had a staring spell? Have you done something embarrassing? Have you misunderstood what's going on? It does carry a small but definite mortality risk, so it's not a benign disorder. And epilepsy profoundly affects a family's function. Parents, whether they can leave a child somewhere, whether they can go out of the house. So it really impacts on everybody around that person with epilepsy. So when we think about epilepsy, there are two broad groups that we put most of the patients can fit into. The firstly, generalised epilepsies, where you have seizures coming from both sides of the brain. We call them bilateral networks. And these have been thought of as genetic. And here is lovely clinical genetic evidence of this. We have identical triplets, pretty rare, and you can see they have an identical EEG abnormality, and they have juvenile myotonic epilepsy. So that's a very sort of normal epilepsy that occurs in common epilepsy occurring in normal individuals. So that's nice clinical genetic evidence. You don't need genes to show this is genetic. You have identical triplets. The other half of the big picture are focal seizures, which begin in one part of the brain and remain often localised or might go to the other side. And historically, focal seizures were considered acquired. And when we mean acquired, we think of structural changes. So here you see an MRI of the brain through this angle, and you can see that there's a structural abnormality if you compare one side from the other. And this is the most common cause of uncontrolled focal epilepsy. And this is where you have scarring of the middle part of the temporal lobe called hippocampal sclerosis. So if you look here, it's all shrunken, there's a bit of black here, which is the fluid, compared with the normal side. And if you look at the whole side, the whole temporal lobe on that side is much more meaty than this side, so the whole temporal lobe is shrunken. So when I started my PhD, just over 20 years ago, people said that focal epilepsy was structural, it was acquired due to damage to the brain or a tumour, and people did not believe it was genetic. So let's go on then to the beginning of my PhD, which led to the first gene for epilepsy. And here you see a 4-year-old girl that I look after, and she has nocturnal frontal lobe epilepsy. Just put volume up. And she does this about 12 times a night. And she has retained awareness through this. She knows she's doing it, she can't control it, it's very scary. And she goes to sleep, and 10 minutes later she does it all again. So you can imagine how sleep deprived the little girl is. And she's developmentally delayed because of her very severe genetic epilepsy. So she has a disorder called Autosomal Dominant Nocturnal Frontal Lobe Epilepsy, which we described back in 94 and 95. And this begins typically in childhood, around 8 to 12 years. The more severe patients begin earlier. And you can see the range is quite big, from 2 months to 52 years. It's characterised by clusters of these nocturnal motor seizures, very motor. They might have hyperkinetic episode, like you saw, just really overactive, or stiffen, and stiffen so badly that the adults have sometimes bent their bed head, that they're pulling on so hard. They have a median of 8 seizures per night, and they sometimes have an aura, so they go from sleep, they awaken with an aura and go into the seizure. The EEG is not helpful at all because they're moving so much, it's just got movement artifact. And it's often misdiagnosed. Some people think it's normal to do that every night. Many think it's a parasomnia, so it's a sleep disorder but not epileptic. And some individuals were even diagnosed with hysteria because they were aware, and people said, oh, you can't be aware through a seizure, and that's not correct. And it follows autosomal dominant inheritance with 75% penetrance. So just for those of you contemplating a PhD or possibly doing a PhD, this is where we started with 2 little families. The year of my PhD life later, we had a pedigree like this, 27 affected individuals over 6 generations. Now, I never go in the lab, I should confess this. I take blood and that's where it ends, and then I have fantastic molecular collaborators. And John Mully in Adelaide mapped this family to chromosome 20q, and went on with a German collaborator called Alfred Steinlein to find the first epilepsy gene in 1995 in focal epilepsy. And that really overturned the idea that focal epilepsy could not be genetic. And this was what the gene was. It was a neuronal nicotinic acetylcholine receptor, and indeed the mutation was right here at the ion channel gate, in that gateway into the cell. And this led the way for epilepsies to be regarded as disorders of ion channels, so epilepsy channelopathies. So where we are now was that we had thought that focal epilepsy could be genetic, but it was in these rare autosomal dominant families. And we know that focal epilepsy accounts for 60% of all epilepsy, and that many people have regarded that genes are not relevant to common or garden focal epilepsies. And because of time, I'm not going to tell you about a story from just the last year, but just to tell you that we've really overturned that now a whole lot further, it's almost 20 years later, and by finding a gene for common focal epilepsy. So I think that there's still a lot more that needs to be done in terms of the focal epilepsy and genetics. And we really still need to modify neurologists thinking that their patients may have genetic disorders. And this is exciting because you find new genes, new pathways, and that leads on to new treatments. And the basic science has a major role in developing these ideas of new treatments. And Carol Milligan's in the audience. She's been working with the gene that we've just found recently for this little girl, and in fact found a potential new treatment that was just published in the last month in a journal called Annals of Neurology, and we're about to start trialling that in patients. So the journey of research is very exciting. So the other story I wanted to talk about was our vaccine story, and in order to do that I need to start by telling you about how we approach a patient with epilepsy. And we approach them by trying to diagnose their electroclinical syndrome. And this is like a puzzle where you put a whole lot of pieces together. So you look at what age that the seizures start in the child or the adult, what seizure type they first come along with, what other seizure types might develop, what happens with that child's development. Were they normal and became abnormal? Were they never normal? Or did they remain normal? What about their examination and neurological features? What did they show? How about their EEG and their MRI? And if you're lucky, what about genes? We don't know that many genes yet, but we probably know towards about 40, but most of the patients with genetic epilepsies are not solved. We've got a long way to go. And if you've got all that together, you get an epilepsy syndrome. And you can have an epilepsy syndrome without the genes as well. Now, this approach is very important for every patient I see, but it's particularly important in the group of disorders called the epileptic encephalopathies, and that's a very long phrase. But it really makes up a large part of my work these days. And these are very sick children who are usually intellectually impaired, and they have constant epileptiform activity. So if you have a look, this is an EEG behind, and between those two marks is 1 second. So you can see a discharge this second, there's one in this second, one in this second, one in this second. So basically their brain is being battered by constant epileptic activity, and that epileptic activity is stopping that child developing and often leads to behavioural impairments. And it's not just the seizures, it's this barrage of the brain with epileptic activity. So I'm going to tell you now about a syndrome I've done a lot of work in called Dravet Syndrome. And this is where you have a perfectly fine and well developmentally normal baby, 6 months old, and they come along with a seizure just down one side, a jerking seizure, and it's usually prolonged, often triggered by fever. And then between 6 and 12 months they may have recurrent episodes of this. So I saw a 22-month-old girl with this yesterday, and in 1 year she has had 20 prolonged seizures, just to give you an idea. They then go on and develop other types of seizures. This is a 22-month-old boy, and he's having the flashing lights to trigger seizures. And so this is called a myoclonic seizure because he's just having a few jerks triggered by that photic stimulator. And this is a very common seizure type in this syndrome, where they get focal seizures, the jerks, absence, which are just staring spells, and often days of not being with you because they have so much epileptic activity, which we call non-convulsive status. These children then follow a specific developmental course, so they're absolutely normal in the first year of life, and then between 1 and 2, their learning plateaus. They walk at a little late, at 17 to 18 months. They regress with their prolonged seizures, and they almost always have intellectual disability. About half are severe, and then you have moderate and mild. And I only have one patient who is of normal intellect, and I've probably been involved with about 100 to 150. So the examination findings in these patients is that they become a little unsteady over time. As they're older, they develop this gait, which is called a crouch gait, and that's really after about 9 years when they go through puberty. And this limits their long distance walking, but that's not present when they're younger. Their EEG is normal in the first couple of years. They're having lots of seizures, but their EEG is normal. But then it becomes very abnormal with lots of epileptic activity, and here you see what we call a regular generalized spike wave. And the genes, well, the genes are really interesting here. This is the first gene found for these severe epilepsies, and there are many of them, many different genes now known, but this appears to be one of the most important. And this is the gene encoding the alpha subunit of the sodium channel. So you see the sodium channel, which is a gateway in the cell membrane, and this little gateway allows the sodium ions to pass through it. And the alpha subunit makes this particular ion channel core, and it has 4 transmembrane domains, as you see here. And if you look at them spelled out like this, you can see the 4 different domains. And we now know of more than 1,000 different mutations in this gene, and about half of them are truncation mutations, which is where the protein doesn't get made, and about half are missense mutations. And now I think about 90% of Dravet children and adults have SCN1A mutations. Most of these are new in that child, but about 5% are in fact from their parents, but their parents have mild epilepsies and they have milder mutations, missense mutations. So it's really a very devastating disease. So if one thinks about a little puzzle, what's the puzzle for Dravet syndrome? And you need all of those factors together to make a diagnosis. And about, as I said, 90% have SCN1A. This month we've just brought out just published 2 new genes for Dravet syndrome, but they're only accounting for a very small proportion. So the vast majority have SCN1A. So it's sort of a really good prototype for our work because it's the only one that's essentially solved. Whereas most of the other epilepsies, there may be a gene that accounts for some cases, but not solved to the particular syndrome. So with that as background, I wanted to move on to vaccination and epilepsy. And as you know, vaccination is extremely topical, And this is not that long ago, in May 1993, the London Times, victim of whooping cough vaccine, won a very large payout for what that vaccine did to the child's brain. So this child had what we call vaccine encephalopathy, and what we mean by that is the sudden development of encephalopathy with seizures and developmental regression in a previously normal baby. So encephalopathy just means disorders of the brain. And so you have a normal baby, they suddenly get seizures and regression. Sounds a bit familiar, doesn't it? And there's long been a claim of a causal link to the whooping cough or pertussis component of diphtheria, tetanus, pertussis vaccination. And this has public health consequences, as I'm sure you're well aware, with poor vaccine uptake and medico-legal implications. Now, despite these claims, there are large-scale epidemiological studies that show, in fact, it's not true, there is no link. But if you're a parent and your child starts having a seizure within 24 hours of vaccination, it's very hard to have you believe that the vaccine didn't do it. So we've done 2 studies on this topic, and the first one was in 2006, where we got 14 cases of so-called vaccine encephalopathy. And this was defined as within 48 hours of vaccination, the child went from normal to developing seizures. And we went back over the history of those 14 cases, and the eldest was 47 years old. So it's very hard to get the early history on the 47-year-olds, but thankfully the mother was still alive for that one. And we phenotyped them, which means you try and make a syndromic diagnosis, and we thought that 12 of the 14 had Dravet Syndrome. 13 of the 14 had onset with their triple antigen, so their pertussis, diphtheria, tetanus, and 11 of those had SCN1A mutations. So we showed that this so-called vaccine encephalopathy wasn't due to the vaccine at all, it was due to a genetic cause rather than an immune cause in response to the vaccine. And we thought that the vaccine was at the most a trigger for genetically determined disease. Now, the families argued that it was a vaccine that did it because they had no family history of epilepsy, so it can't be genetic. But the reason for this is explained because we showed that they were de novo mutations. So mum and dad don't have de novo means new in the child, and therefore there was no family history. So this finding has societal and medico-legal implications. We then went on to a second study, and we took 40 patients with Dravet Syndrome and a proven SCN1A mutation, and we sourced the actual hospital records of the timing of their first seizure, and we got their baby books to look at the timing of vaccination, and then we looked at the time between vaccination and seizure onset. So this, in fact, is the baby book of my colleague Sam Berkowicz's little 6'6" son, and this is Sam here at his son's wedding. And you can see that vaccination was very good for his son, he grew well. And but you can see here the baby book, and the baby book shows the date on which he was vaccinated, but not the time of vaccination. So we could only look at that and figure out how close to the date in terms of we can look at exact hourly correlations. So is there a relationship between vaccination and Dravet syndrome at all, or was it just because they had to blame something, and we all want to blame something if we can? Well, the families were right. There was definitely a correlation, and we had 24 vaccine distant cases, and we had 13 vaccine proximate cases as within the first 2 days of vaccination. And we looked at this very carefully and said, are these cases, the vaccine proximate cases, are they any different to the vaccine distant cases? And the answer was no. The only difference was that they had a 7-week earlier onset, so most of them began with a 4-month vaccination. We have triple antigen at 2, 4 and 6 months, and they mostly began with a 4-month one. And interestingly, a third of our Dravet cases are associated with vaccination. And as best as we could tell with this data, the vulnerable period was within 40 hours of vaccination. And the infant, we believe, is destined to have Dravet syndrome, but the vaccine triggered the onset. And if it wasn't vaccine, it would have been the next febrile illness. So what can we surmise from these studies? Firstly, there's no contraindication to vaccination, but obviously people are worried about this. And so we now recommend to arrange for vaccination in a safe environment. And in fact, with this little girl I saw yesterday for the first time, a 22-monther, I said to the family, they hadn't vaccinated her since her 12-month vaccinations, that we should send her to the vaccination clinic at the children's. There's some question about whether pre-medication with paracetamol would make any difference. I suspect not, because we found that of our cases in the first study, most of them did not have a fever at onset, so the vaccine is working in a different pathway. And we think they're destined to have the seizure at that time, which is probably when SCN1A becomes relevant, and we know that from animal studies. So the next stress on that baby's body, be it vaccination or fever, would have been caused. So this story is relevant to a broader audience though, and I don't know, did any of you see Jabbed last year, last May when it came out? Put up your hand if you saw it. Okay, so a whole room left to see it. You can watch it on SBS or on YouTube. It's a fantastic movie documentary by an Emmy Award-winning Australian film director called Sonia Pemberton, and it's anti-vaccination lobbying. And there are 6 intertwined stories, of which Dravet is just one of those stories. And she does just a magnificent job of bringing both of the views to the table about vaccination and letting you decide for yourself. And it takes, the Australian version is an hour and a quarter. She's now sold it to both Europe and America. And it's just a beautiful example of a movie documentary. And this is really important for another major debate in our society, which is autism. You know, the autism people believe very strongly that measles, mumps, rubella, which is given around the same timing as regression occurs in about a third of children with autism. And so a lot of the families believe strongly it's the vaccination. And yet there's more evidence that autism is genetic than for epilepsy. So I think it'll be the same sort of tale. All right, so let's get on to the more general topics of why bother with science. And I gather that we have a mixture of biomedicine students here and science students and maybe some medical students as well. So I think this is really relevant to all of you. And let's go back 125 years. These are the first women in medicine at this university. And they were pretty against them even doing medicine. It was unwomanly and would unsex them. And it gets worse. They refused to give them jobs. The Royal Melbourne Hospital Committee declared that the work was far too strenuous and trying for us. There was debate about whether this was even a suitable subject for women. And they thought about separate lectures, dissection and hospital practice. So they had a very hard time, and these women actually went on to set up the Queen Victoria Hospital because they couldn't get jobs. So that's where we were 125 years ago. Now I think of myself as a physician-scientist, and so that's been a fairly recent realisation to me, despite the fact that I've done research for 20 years. And it's sort of not what I signed up for. When I did medicine, I thought, I'm going to be a medical doctor, and I'm not really seeing myself as a scientist at all. But why is it a really good thing to do? It's because it makes my work much more interesting. And I manage with my work to touch a lot more patients than I can see in a day. I go around the world teaching lots of other colleagues about the stories that we found, the science, and that really makes a difference to their patients as well. Many people say that these days you're going to have 3 careers in a lifetime. Well, I have 3 careers in a week. And I think that's a very exciting way to live life. And the other thing to point out, that clinical research is not basic science, and I think it's a lot of fun. I know basic science is fun too, Carol, but I think it's a lot of fun, clinical research. And one of the things I wanted to highlight is the excitement of that moment of discovery. And I think that's really special. When you're seeing a patient or you're in the lab and you suddenly find something and you go, wow, this could mean that. And nobody else in the world has done that yet. And wow, isn't that exciting, and this could make a difference. So I just wanted to emphasise that that's a really wow moment, that aha moment people talk about. But what about clinical research? Some would regard the PhD as the beacon of a research career, and I have a PhD and I'm very proud of it. But some people look down on the poor cousin with a Bachelor of Clinical Science, and how could they possibly be doing real research? So why is clinical science so undervalued? It's perceived as less scientific, and this is partly because clinical research doesn't really get published in Nature or Science. It does if you work with other people that help you to augment your science and give it much more depth at a scientific level. But if you just do clinical science, you really can't get in those top tier journals. The other point is that we're dealing with those funny things called human beings, and you often don't get black and white answers. I think it's partly our fault. I think sometimes we're not as rigorous about our science, but it's partly the nature of what we do, and we sometimes define our conclusions poorly. So if you're going to do it, you have to do it really well. So I've given you all this negative talk about it. Why bother? Well, I think the really good thing about clinical research is it gives you a different way of looking at the world. And as I said before, you can make a difference way beyond the patients that you see. You can have a global impact, and I certainly see that with our research, that we touch people all over the world and families right from all over the world. We can change practice, and that can change outcomes. So just to go back to the example I told you about Dravet Syndrome, we now know some drugs that were used historically a lot in Dravet Syndrome make those children worse, and some drugs make them better. So if you just stop the doctors using the wrong drugs, anti-epileptic drugs, and you use the right ones, there are already improvements in cognition that people are seeing. So that's even at the most rudimentary level, let alone thinking about targeted therapies, which is where we want to head. So who should do research, clinical research? Should it just be physicians and surgeons? No, not at all. It should be speech pathologists, nurses, physiotherapists, dietitians, psychologists. We all have a responsibility to think about research in our careers. So is it part of your day job? Well, the first thing to say is it takes a clinician. You have to be a clinician to do clinical research. And I don't say that lightly. To be a paediatric neurologist is only 13 years of your life. And by the time I finished my PhD, it was 21 years of my life since leaving school. So it's a long haul. So one of the things that I love is that every patient I see raises new research questions. They inform my science, and then I've got to look at that patient and say, what's that patient telling me that's different? And how can I design an experiment to answer that question properly and take the science further forward? One case doesn't help you, but you have to pick out what's special in your patient. So is it part of your day job? Should you just be able to go and do clinical research? Well, I think sometimes we think we can do it when we're not adequately trained to do it. As when you do your clinical training, you might get a bit of a taste of research. They might, at the moment, the final year med students at this university are doing their scholarly selective, and it's a 6-month period of time. But at the most, it's a tiny taste of research. It's not really getting your hands dirty. So how should you do it? Well, I think you should do a PhD, but you can do a PhD in clinical research, not just basic science. It's a new career. You shouldn't expect to walk in and know how to do it. You've got to choose a good mentor. That's the key. It doesn't matter quite so much what the question is. If you've got a good mentor, they'll know what a good question is. And I wrote the 20 drafts to remind you that I tell all my students every paper has a minimum of 20 drafts, and I'm not kidding. And my own papers have about 50 drafts, just to tell you how tough I am. And I just spent the weekend in Taiwan with one of our adult neurologists who's just gone back and finished his PhD. I think it's just got it in the mail, actually, the book. So it's just passed. And he said, oh, I learned so much about the 20 drafts. Anyway, so it takes time and dedication. And why do you want a PhD? Because you want to develop scientific thinking, and that's not really what you're taught in medical school. And you need to have a scientific framework with hypotheses, aims, methods, results, conclusions, and critical analysis. And in fact, today we were working on our next program, and it's exactly the sorts of things that we were thinking about. So what about scientific output? You can't be a scientist without publishing. And you have an obligation to do that to the society. Our society is funding the research. If you have NHMRC, National Health and Medical Research Council funding, you're funded by the research, by the community, and you have an obligation to publish your findings. Even negative findings deserve to be published, because otherwise someone else will go and waste the same resources doing the same experiment that you did. And if you can publish it, then at least you save someone else expending their energy. The other reason you have to publish is that your career as a researcher depends on your research output. So you have to get high quality papers to ensure that you'll continue to be able to be funded to do all these P's here that you can see. So what about the downside? What do we have to think about? Well, you have to think about dealing with disappointment. Experiments fail. You can have a great hypothesis and it falls over. Papers are rejected, sometimes multiple times, and that's where a good mentor helps to get into the right journal. Grants are not successful. You can be overlooked for a position or a promotion. So you need resilience, and that's really important. It's not something for the very emotionally fragile, and you need a good mentor. When you do go do science, what you need to work on is taking it to the next level. So I start off with clinical observation with my patients. I then work with my gene finding colleagues to look for the cause. We then work with our physiologists to look at the mechanism, and our imaging people to understand what the brain looks like with that gene. And then it's my job to translate it back to patients, and I think that's really important. So just to give you an example, vaccine encephalopathy, we showed it was due to SCN1A, but we got this idea from the clinic, not from the molecular lab. We said that this vaccine encephalopathy is actually Dravet disease. And then we got our physiology colleagues have got animal models and shown that this SCN1A mutation results in a problem or abnormal function of the inhibitory interneurons. And at a clinical level, we have an important role in dispelling the belief that the vaccine is causative. And in fact, there was a child in the UK that had a mutation and had a large payout in our original study, and the parents wouldn't send their DNA because I don't think they wanted to know the answer. So in order to do this, taking your science to the next level, what should you need? Well, you need teams. Team science is really important, and you need people with different skills. So from the clinic to the laboratory to the animal people who look at the little mice and see what they do, or now the zebrafish or the flies, to the imaging people. And I think one of the things that's really important is that team science is really fun. You have lots of people that bring different skills to the table. They have different approaches to a scientific question. They can use different methodologies and take the whole science in a different direction. Animal models are really important for development of novel therapies because you can do a lot more to a rat than you can to one of our patients. And once you've test-driven them on the rat, then you're in a position where you can go and look at the patient. And the other thing is it's exciting. You find something you didn't expect. You're working with your colleagues and you come up with new answers. So I would certainly promote that to you. So what about women? What do they add? Well, I think that women can add a lot more to the picture. We add a different perspective. We're 50% of the population, and our society can't afford to lose half our intellectual strength. We bring different views to a problem. We approach problems in different ways and produce different solutions. I don't think we're better. I don't think we're worse. We're just complementary. We also have very different leadership styles. Women often run their groups in a more horizontal structure, and perhaps some may have more democratic decision making. And I think some people suit different people. So I run my research group with a male colleague, and we have very different styles, but I think we're very complementary in how we run our group. And I think some people are suited to male leadership styles and others to females, and I don't think it matters, but I just think that they're different, and we need to recognise that when we're trying to grow women. So lots of people ask me about balance, and that's a very difficult area. By day, a respected scientist, at night, hideously transformed into a slave. And I think that lots of women do find this difficult. And how do you actually know which of these incredibly important careers you're going to do and which are you going to give up? And can you do it all? Well, I don't think you can do all these careers. And so one of my lectures to anyone who wants to listen to me, and to my colleague's wife in Taiwan on the weekend, was get a cleaning lady. I don't even try to clean the house, I have a wonderful cleaning lady. So those sorts of things, you can't do it all, you have to figure out what you're going to give up. So that you could eat off her floors, I'm sure you could eat off my cleaning lady's floors. That's not mine. So how do you achieve balance? Well, I'm the last person you should ask that. I would say you have to work very hard, you have to be committed, and you have to be passionate about what you do. And I'm passionate about my patients, and I'm passionate about my science. You need to ensure you have other interests to give you perspective, and I can't say I always achieve that well. And I'm a major believer in multitasking. Now, my husband doesn't believe in it at all, and I'm sure it's on the X chromosome, the gene. So it is a juggling act, and time becomes a very precious commodity. You have to work out how you're going to spend your time. So is it easier for you guys than it was for me? I don't know. I think in some ways yes, and in some ways no. So we certainly have more equal career partnerships now. Your partners will be expecting to do as much of the baby care you would hope. And you can plan careers together, and you can alternate career priorities. So a year or two favouring your career and a year or two favouring his. The childcare availabilities have improved, but there are still those key questions. When the child's sick, who's meant to go and pick up the child? Now, I thought for years my husband would realise that he was the one who was meant to go. Because he's the engineer and I'm the doctor seeing some patients who've driven 6 hours to see me. But, you know, thankfully we always had backup, and our children were very well, we were very fortunate. But I realised after some years that really he didn't realise that would be his job, so we obviously on a completely different page. And now as you get older, who looks after the ageing parents? You know, his mother's very sick, who should be staying home to look after her? And I think these things are still often fall to the woman, even though you don't think that they should be. So is it better? I think it's better. I don't think the problem's fixed. So one of the things that Jordana asked me to address was what were the challenges for me? And I think for me one of the challenges was confidence. I certainly was not confident when I started in science or even in medicine. And I felt like I really needed to know I was on top of my area to be able to talk about it. Certainly couldn't give a talk to save myself. And I know these days you're all much better at that. I have a very different style to the male colleagues I work with, and I see that every day. And I'm still in a very male world. And politics, I think, are the most taxing part of our daily life. And I suspect that's still in many boardrooms and corporate organisations. Politics are really what make life tough. I guess I put the next line in about the recognition that I'm a scientist. I wouldn't have called myself a scientist really. I wouldn't have believed that I was a scientist until I got the Loreal UNESCO Award, and then I thought, oh, now I can call myself a scientist. So now I'm quite proud about that. And I think the other challenges is balancing and prioritising life. And I can't say that I've always done that very well, but my boys are wonderful and life's good, so there must be something okay. And also leadership. I don't think anyone ever tells you when you're leading something well or doing something well, but I do enjoy, you know, having a wonderful team of people that I work with, and so I guess that it also took a while to realise I could do that. So part of my issues were gender related, I think. Now, these are vast generalisations, so you can throw all the rotten tomatoes you like, but basically I think that women often need to know something really well to appear confident, and men often can appear very confident with a much broader knowledge but less detail. So they don't have to be as on top of their field, and if you probe, they may not know the detail. Women are less good at projecting themselves, and culturally it's not regarded as feminine, because men are, if a man is very strong, they're assertive. If a woman's very strong, they're aggressive. And this is very important when you're looking at job promotions or two people going for a job, because they'll often project very differently. What about self-confidence? Well, I think it's lacking in many women, and especially in the past. I think that your generation is different, and that's probably good. You don't want to be men though, it's important. I've got with one man obviously. And the question is it nature or is it nurture? And I don't think we really know that. So the question now for you is, have we made it? You know, 1887, there's the poor women who shouldn't have even done medicine, and have we made it is the story all over. Well, you might have argued that a couple of years ago we had a female Prime Minister, the wonderful Dame Quinton, a female House of Speakers, leader of the House, Speaker of the House, even our first female President of the Australian Academy of Science. So some would say we were there. But, you know, is there really there? Are we really there yet? 50% of undergraduate and PhD students are women, but only 10% of professors in this university and in most places in the world are women. And this is the same in boardrooms, and you read this in the paper every week, that 8 to 10% of boardrooms, directors are women. Certainly true in medicine, and particularly in surgery and obstetrics and those sorts of areas, and in the research institutes. So is this just our problem as women? I would put it to you that it's not. I would put it to you that it's everyone's problem. It's a global issue. And an example is that racism is not a problem of just one race. It's a problem that we all have to own, and the men have to own it as well. So why is this a problem? Well, the first thing is that our biological clock. Women are not as competitive after maternity leave. They have the childbearing years happening exactly at the time they're finishing their PhD and looking at postdoc. They end up being too far behind their male colleagues. They don't have enough grants, they don't have enough publications, they can't keep their research projects going. Many women find the balance of clinical career and family already difficult enough, so that they forego their research. And I would argue though that family gives them breadth and perspective, so that they do their other aspects, their research and their clinical side of life better. And perhaps it may make them more broad senior scientists and managers. So you don't have to have children, but I just think that it does bring something else to the breadth of the scientist. Now, so some of these problems one would regard as first world problems, and aren't we lucky to have a degree of dilemma? Other societies are much more difficult, and women are certainly not equal. And we have a lot of international fellows who come and work with us for years at a time. And I had a Korean fellow, a wonderful young woman, and she just couldn't believe the equality in our society, and explained to me that she would be in the hierarchy for the rest of her life. And certainly I saw that in Taiwan on the weekend. But that was a male colleague in Taiwan. But the hierarchical structure is still very strong. So there are not the same opportunities for women and men around the world, and we are very lucky in Australia with how we sit. So how do we achieve equality? The first thing is we have to stop saying that there is equality, because there isn't, and we need to recognise it. It is built into all the structures and workplaces within the hospitals and universities, and I believe we do need some preferential training paths for women. We need female mentors, and we need to promote women not because they are women, but because they are bright and focused. And you know, my election to the Academy of Science today is interesting, because I don't know if you're familiar with what happened a year ago, but basically the Australian Academy of Sciences had 10% women fellows, or less than, and about last May, Doug Hilton, who's the director of the MUHI across the road, wrote a letter to Nature basically saying that the Australian Academy of Science only had 10% women, and isn't this appalling? So if you like, I've been nominated in a very good year to be a woman, and I just looked at of the 21 successful people, 10 were women. So obviously that's given that a bit of a boost. But you might say, well, do you want to be a second-rate woman that gets in? And hopefully I'm not. So where are we at then? I think we've come a long way from these poor ladies, and I hope I've shown you that clinical research offers exciting opportunities, that it's your job as a clinician to recognise the patients who raise scientific questions, to design experiments to answer the questions, and that we can have surprising findings that often lead to important biological insights, and then we have to translate them to the bench with basic scientists and take them back to our patients. So can you have it all? Well, I think you can. Here are my gorgeous boys and husband, and you have to make choices, and you have to define how you achieve balance. It may not be how the non-working mother out there achieves balance, and you have to work hard, but you can have greater outcomes, like my 2 outcomes there. And just to remind you of that exciting moment of scientific discovery. So, yes, you can be a woman with attitude, with vision, focus, support, hard work and inspiration. But I couldn't do it without our fantastic team, and we're up for our 20th annual epilepsy research retreat this year, and this is the fantastic team of our own team and the collaborators we work with, and particularly this man here, Sam Berkovic, who just received an AC. I've worked with him for 20 years, a great privilege, and really fun. He makes our science great fun because we have a lot of intellectual debate, and we enjoy leading our team together. So thank you very much for your attention.